Thank you everyone for coming. This is the inaugural COBRA rounds, and everyone asked where the name COBRA came from. Honestly, I was looking for something to name COBRA afterwards. So I wanted COBRA as a name, and it just happened that Byers Eye Institute begins with a B. So we knew Cole was the beginning. So that's why I stand for. No, I'm just kidding. Brittany and I go way back, and we were co-fellows together, and we have always talked about trying to find ways to, educate surgically. And, obviously we've learned a lot in the past year about how we can, really communicate with each other. And we really wanted to do something that was geared towards fellows and specifically geared to like some of the nuanced steps. So this is where Cotton Cobra came from. It's a very laid back, it's supposed to be interactive and fun. For those who are joining us, feel free to ask a question. If you rather do it via chat, feel free and we'll answer it. We're going to go through we're going to have themes throughout these rounds. And if you've seen the website, we're hoping to have 6 over the next year. We're going to have 3 already scheduled. I'm going to thank Bausch and Lam, and Rob Nemeth from Bausch is going to say a few words for supporting this. I'm going to thank my colleagues who are on the phone, on the call, specifically Kat Talcott from Cleveland Clinic, Danny Memo, who's our second-year fellow. I'm going to let Prithvi introduce his crew, and I'm going to let Rob say a few words first, and then Prithvi, it's all yours.
Yeah, thank you. I appreciate the time. So I'm Rob Nemeth. I'm the Director of Marketing for Bausch & Lomb's Retina program. Truly a privilege to do this. Sunil and I talked a little bit about this idea and just love the outreach. And I know this team of faculty is going to present some really interesting cases tonight and have a really, really good discussion. So feel really privileged to be a part of it. Don't want to take up a ton of time. Bausch & Lomb, we love retina. My background's actually from Synergetics, a smaller retina company who really focused on unique niche pieces and parts to support it. We brought that piece into Bausch & Lomb about 6 years ago. It led to what is our Stellaris Elite platform now, supports our 16,000 cut per minute bi-blade cutter. We continue though to invest in what's next. Vitesse hypersonic technology, if you've heard about that, but also a lot of pieces and parts and unique instrumentation. We recently released a new Vortex for IOL fixation, really neat, unique tool for anybody doing IOL fixation, which we know is seeing a bigger prevalence now. But also I want to talk about on a macro level, big changes inside of our organization. For a long time now, Bausch & Lomb has been housed under the umbrella of Bausch Health, which was formerly known as Valiant. We are in the final stages of being spun off into a pure play eye health company. That is going to be surgical, pharmaceutical, vision care, and consumer. We're really excited on this because then we can focus all our strategies and all our investments on ophthalmology. We think it's really going to unlock some opportunity in the future to bring new technologies to market, and look forward to working with all you going forward. So appreciate the time tonight. I look forward to a great meeting. Thank you.
Thanks, Rob, and thanks, Sunil, for combining our side of the world with yours, East Coast, West Coast. Actually, Cleveland's like not really coast anything, but it's okay. It's still warm there right now. So Sunil and I go back a long way, as you mentioned, and the fundamental aspect of our surgical retina training was really our ability to interact with our faculty and dissect cases on a weekly basis in our vitreoretinal surgical rounds. So we would be seeing patients live post-ops with all the faculty, and going up to a whiteboard and writing out our cases and what we thought we did, even though it was probably wrong most of the time. At least it was wrong when I said, when I was talking. But I think what we've both understood is the importance of being able to dissect cases step by step for fellows. It makes we as teachers better because we observe more of what's going on. But for the trainee, I think it really helps to see the steps as they come. So the purpose of these videos that we're going to interact with today is not to show the slickest, most polished 2-minute video of a complex case, but really to take it step by step. So we have a fantastic faculty here, and we'll get to know all of them through the course of tonight and over the 6 sessions that we have planned. But most importantly, an early round of applause for the fellows who are putting themselves out there, showing the steps of what they're doing. Sometimes it may not look as pretty as they go, but you know what? At the end, it's about putting it all together and doing the right thing for our patients. So, without further ado, I'd like to introduce my partner at the Byers Eye Institute, Dr. Edward Wood. Edward was a resident with us at Stanford and completed his fellowship at William Beaumont and joined us back just a few years ago. And Edward's going to be proctoring a couple of cases with us. And our first presenter is one of our second-year fellows, Dr. Eddie Carote. Eddie joined us also from Beaumont, where he's a resident, via London, where he did a year of medical retina and research, and has now been a fantastic member of our crew. So Edward Wood and Eddie Carote, I'll turn it over to you guys. Thanks.
Thank you, Prithvi. Eddie, why don't you go ahead and introduce your case and we can go from there.
Sure, I'll start screen sharing here. Great. Can you guys see my screen here?
Looks great.
Awesome. So welcome to COBRA rounds. This apparently is a cobra, and its eye is pretty large. So I thought that would be kind of interesting to show.
It's a great start, Eddie. We're on the way.
All right, let's get going. 73-year-old female presents with decreased vision in the left eye. She's got pathologic myopia with a 30-millimeter axial length. Per the patient, she has a history of macular buckle in both eyes, although we couldn't find evidence of that on exam to be super apparent. She also has, of note, in the other eye, a macular hole that was repaired with a pars plana vitrectomy last year. And her presenting vision's 20/60 in this eye. So here's a couple OCT scans. It's a raster scan on the Zeiss. The top panel is through the fovea, and you can see some subretinal fluid there, causing a shallow detachment, a pretty large staphyloma. And then a more inferior scan down low, you can see some posterior hyaloid interface causing some skytic changes and some apparent vitreomacular attraction there. That's potentially causing some of those skytic changes. Here's a optos fundus photo of the.
Hey, Eddie, can you go back to the OCT?
Yeah.
These are great slices. What are some other things you might think about on an OCT on a patient like this in order to get a great visualization of the fovea to ensure you're doing the right thing in this surgery?
Sure. So you might think about some different kinds of scan protocols. You might think about a radial OCT scan just to make sure that there's no holes there that you're missing, as well as to categorize your subretinal fluid there a little bit more. Potentially, you can get some wider scans as well to see if there's any peripheral pathology or like subtle breaks as well.
Yeah, that's great.
So here's a optos fundus photo of the same. You can see the diffuse chorioretinal changes in the posterior pole, a lot of peripapillary atrophy, disc tilting consistent with a very myopic fundus. So we'll go into the case here.
And the decision for surgery was because she noticed progressive vision decline in this eye?
Correct.
Okay. And then before you're doing this, did you put a block in? Did you do like, what was your anesthesia like? And because it's a long eye,
Sure.
Do you think about doing anesthesia any differently for very long eyes?
Yeah, so we consider for long eyes avoiding a retrobulbar and potentially doing a peribulbar. But I think we did a retrobulbar block here, just being careful.
Yeah. Okay.
So we're putting in the trocars here, and going inside the eye, we immediately put some triessence because we expect there to be some vitreoschisis. And the primary goal of this case is to get a good, good PVD and to get the entire hyaloid up. And here we notice that the view is bad and going out of the center, and that's because I'm actually hitting the recite with my instruments as I'm trying to get to the back of this 30 millimeter eye.
So can we pause there again? Sorry to
Sure.
keep pausing and talking all the time, but I think I'd love to maybe just throw this question out to some other members of the group, maybe some of the other fellows. So I love how there's an axial length on this case, but I mean, how do you know that? The patient doesn't have that written on their forehead when you see them. So you ordered that test, right? You asked to get an axial length so you could facilitate preoperative planning for this patient. So in a very long eye, what are some things you might think about doing to make sure you have the right instrumentation during the case, or yeah, you even be able in some of these cases to reach the back of the eye? So I think you thought about making sure first of all, you got an axial length, which was fantastic. And you thought about that approach, but let's say the eye is very long. You can employ the help of Rob and Synergetics and Bosch and Lomb, who can talk to us today, maybe even about long forceps that they can offer for us and when to reach out to them. So Rob, can I ask you a question? When should we be reaching out to you for long forceps? Like what's the length of your forceps? And at what axial length do you think it's a good idea to employ Bosch and Lomb extra long forceps? I don't know if he's there.
I think you scared him off, Ed. That's what it was.
Okay.
I think it's a really good question though.
It is a great question.
Yeah, I think like one of the points too here is that, you know, you guys are lucky to have obviously have what the axial length is, but we often don't know what it is. So I don't know if, you know, any of the other faculty sort of use any of their clues, but sort of when I'm sort of evaluating these patients, even if I don't know what the axial length is, I try and sort of pay attention to like, you know, is there peripheral atrophy surrounding the nerve, sort of, you know, what does the schisis look like? And I just assume that these eyes are super long. I think it's okay to do like retrobarbos for these patients. You just have to be very cognizant, I think, of the entrance of your needle. Certainly a cut down will sort of be able to sort of minimize your risk too. So that's reasonable. You know, I think you can definitely go to sort of different forceps, but, you know, one of the things that sort of I've learned is that sometimes you can use your normal instruments. You just have to really change your hand position. I don't know if Eddie, if you found that was the case during this case, if you had to like move where your hands were to be able to sort of utilize more length, or like what other things you tried.
Yeah, definitely have to shift around the hand because, and then at some point, how I was talking about how the recite was getting bumped, there was really nothing that I was just kind of moving the recite away to compensate and trying to turn the eye because when I was going so vertical, the back end of the instrument was just hitting the recite. And I know that some of at AVTT, they had some instruments, some new Alcon instruments where the grip was actually smaller. And in addition, the back of the instruments can come off to assist with that. So I think that might be helpful as well.
A couple, before we even get into the case, these bring up some really good points. And I think Kapil Mishra just asked the question that I was going to ask. When should we be considering going to 23 gauge, which is just a little bit longer than 25, definitely longer than 27 for these presumed, long eyes or confirmed long eyes by axial length. Sunil, Kat, do you guys have any standing rules on that?
So I'll speak for myself. I don't. I kind of assess the case. I think most of us are comfortable with 23 and 25. That if I thought it was going to be an issue, just going straight to 23. The one thing I do is I like to remove the cannula in order to gain a little extra length, so it's not hitting anything. Yeah. And I think to your point, Eddie, of like hitting the recite, it's positioning that's a fair amount.
Yeah.
And I also think I do a fair amount of my peeling, if you're going to get into peeling, with an instrument that can sometimes reach down there. So whether it's a diamond dusted or a flexible loop, I find that adds a little bit more because a length for me personally. There's so many different strategies here. I think some of it's just your comfort level and what you can get down to.
Yeah.
And I think you're doing the most important thing first is recognizing there's going to be vitreoschisis here, and let's start getting layers off. So that's my 2 cents.
Yeah, I agree.
I'd
I think
also
having,
add, like, sorry.
go ahead, Prithvi.
No, please.
Oh, I was just gonna say, I think definitely having Kenalog or steroid in is a must here, because you know that the most challenging part of this case is probably going to be able to make sure that you're getting all the hyaloid up.
I would add that, we're so used to using the recite or the biome, which can knock into things. But, if you had a handheld lens, this may be like the one time in the year, if you don't use it normally, like it would actually be helpful because you may not knock into it as much with instruments. But I think you can manage around it with all the techniques that everyone's talking about. But
I'm going to warn the fellows, though, if you do handheld instruments with Prithvi, he purposely decenters it so he has to operate. So I would just avoid that because he doesn't know how to
I can
hold it.
attest to that.
Yeah.
It's mainly a torture device for me rather than anything useful.
All right,
How
sorry.
much
keep
nausea
going.
can you
Okay,
induce
sorry,
by
Eddie.
just shaking the lens?
Oh, that's
The
all right.
last thing, I think the last thing I'll say is it can be very helpful in these eyes to place the trocars, and as Eddie's written here, more posteriorly, because if you examine them and mark where their aura is, it's often far posterior to where an anatomic aura is in a axial length eye that's normal. And so that will really help you get away from the recite, help you use normal instruments. You can often do that just by looking and marking before entering the eye. So
And
great.
we have the Eckhart long forceps available to us. We didn't have to use it in this case, but I think it's available if we need it, right? I think.
Yeah.
Yeah, I think if you have a very long eye, planning for it is great, but sometimes you think that it's not that long or you don't expect it to be that long, and knowing and having some tools in your armamentarium of going back and changing things. And even, to the point of putting the trocars more posteriorly, you can actually put in 2, and then if you're peeling and you're worried about it, you can move your third one more posterior even after you're in the eye if you're having issues with reach.
Cool. Thank you guys for that
Great.
awesome discussion. I'm gonna go back here.
You're doing great. We got 10 seconds into your video. I mean, we've already interrupted you 12 times.
COBRA
That's
is striking.
awesome.
So feeling the venom. All right.
Great. So the main goal in this case is to get a good PVD, and so we're gonna spend a lot of time in this case, just as a spoiler, trying to get a PVD.
We appreciate you showing it that way because it's very hard.
Yeah.
It's not easy. So I'd like to see how long it takes you because I think it's real. So great. Tell us what you're thinking.
So first, we're trying one of the main methods that we use is with the vitrector, and you can see I started with my right hand and switched to the left hand to try to not hit the recite as much, and also to try to get that nasal lip of vitreous there. And then we're trying to kind of segment it here, so going radially, because pulling straight up was not working. So trying to go radially from posterior to anterior, and we're frequently reapplying triessence to just visualize the posterior hyaloid better. Again, trying to go radially here. And so I just threw in this other PVD techniques kind of short clip that I had already made for something else, just as kind of a primer on different ways that we can make PVDs in different types of presentations. So here's a kind of fibrotic PVD where we're initiating with ILM forceps. And here's kind of an inflammatory posterior hyaloid where we're segmentally doing the same.
I'm glad you're going over this because I think this is one of the hardest skills at the beginning of fellowship, is to be able to sort of lift a hyaloid. It seems like it's really simple, but it's actually quite a sort of a complicated thing to learn.
Mhm.
I think using liberal amounts of steroid is really helpful here. The other thing that I really find I tell my first year fellows a lot at the beginning of the year is everyone wants to move off the disc really quick. And you really need to be slow and deliberate with your movements, make sure you're in the right position, and sort of really make sure that your cutter is full of gel before you start to move too. But I think it seems simple, but it's a hard thing to master.
Yeah, and sometimes for the really tough ones, you can actually do more. So normally we start on the inside on the optic nerve, and then lift out. Sometimes if you have a little edge somewhere at the edge of the nerve, grabbing there, and then usually going around the nerve and lifting up that way can also work well. So you don't always have to be right in the middle of the nerve.
Yeah, that's a great way to, I think, induce PVDs that Odina Barakal talks a lot about, and we do sometimes in pediatric cases, is that she induces a lot of her PVDs by taking a flex loop in the nasal macula, kind of over where the vitreous is, theoretically least adherent between the fovea and the disc, and inducing a little bit of area of vitreous elevation there, and then taking that back to the disc. Because sometimes, as you said, it can be very stuck down to the disc. So I think that kind of potential space is a great spot, as you mentioned, to keep in mind, like working towards the fovea or towards the disc and then elevating from there.
I'm going to be the old person here and just remind Prithvi will remember this, but we used to talk about a fish strike sign with a soft tip, and that's where you would put it, is just on the temporal part of the nerve, so it's nasal to the fovea, and you would take a lighted pick and essentially try to lift the edge of the hyaloid that's right there with the pick. So it's a really nice technique with a lighted pick and a soft tip, or the cutter if you want to use. Come just nasal side of the nerve, really kind of lift it up, and you'll see it kind of lift, and you can dissect it off of there. So I think that's a great technique.
Thank you. So I'll just draw attention to this area of thinning and kind of increased vitreoretinal adhesion as well, here over the inferior arcade. And we actually spend a lot of time trying to get the vitreous up over that area. And there looks like there might even be some kind of holes there. So we put some more triescents. We're now trying every tool in our bag. We go to the Tano scraper, which is good for kind of these, membranes that are more like gel-like membranes, such as a posterior hyaloid. And we're kind of trying to brush over that area to segment it from the rest of the hyaloid, in a sense.
So Eddie, if you can pause here. So it looks almost like, it's staining what looks like hyaloid, but it's not really connected. It's clearly schitic. So, for the other faculty, what do you do with that? So you're up off, past it in the periphery. You have this like very thin layer. Is the goal to, find that layer and lift it up if you can? But if you can't, are you just trying to disperse it a little bit, break it up? Like what's your endpoint? Because you're only going to create more trouble if you keep scraping and scratching on the retinal surface. So like, what's the endpoint?
I'll tell you, so I think these are challenged me because I think you can make arguments each way. So the argument you can make, and I've heard many say that once you release the traction kind of anterior to the macula, maybe you don't really need to go after this stuff down below. But you look at the OCT anatomy, and that OCT anatomy preoperatively clearly shows that there's AP traction. It's probably an element of tangential traction from the macular fibrosis or the VMT. So I would tell you, you're spending the appropriate amount of time here, because if the goal of this was to put the macular back into position, we're going to need to remove some of this stuff. So I would consider adding another stain maybe at this point to help you figure it out, because I think it's very easy to be fooled. So whether that's your blue or green, everyone has their personal preferences, just like, Destro or Cobra Commando Prithvi. So, I think you just have to figure out which one you like, but I would spend the time here because I think it's important to get the outcome you want.
Yeah, I agree with that. I mean, you see this a lot in a lot of different cases, but I tend to not worry about it when it's not adjacent to worrisome pathology, because I mean, even with a good PVD, you can still see that there's some of that posterior cortical vitreous. But yeah, when it's adjacent to worrisome pathology or in like surgery warranted pathology where it's next to a hole or right next to a tear, or if you're concerned it's a case where you're reoperating and you see this stuff with PVR, I think it's good to go after it.
So Eddie, it looks like you're using, forceps and maybe cutter now, but forceps as well to kind of peel it off more peripherally.
Yeah, so we kind of went more peripheral to just get a wider view and more of a wider sense of what's going on. And then we kind of segmented the posterior hyaloid away and we're just kind of cleaning up a little bit in the periphery. But then we kind of go back to that area, and so you see here we put in some brilliant blue to potentially do a peel to get under that plane as well. So now we go back to the flex loop in that area, in that potential space. And I guess we're here, we're getting the ILM.
Looks like a challenging view.
Yeah.
Is Dr. Muthman J is holding the lens, clearly. That's the problem. Yeah.
So we went with blue here, and we had good stain when we looked at it under the contact lens. I've heard people argue, especially in these high myopes where you don't have a lot of pigmentation behind you, that they prefer the green versus the blue. I don't know. I kind of feel like whatever is giving me a view, I'll take it. But anyone feels strongly that they should go green if you have a pale looking macula versus blue? Sumit, do you have any thoughts?
We use mostly green. We have blue, and I haven't used it a ton. So, but the bulk of my experience is with green. So it's basically what we use for everyone. I haven't really used blue enough, especially in eyes like this, to comment one way or the other.
I feel like once you get that separation, it looks fantastic, but like it's that first step to see the crack. But I think this is looking pretty, you can tell the difference of what's there and what's not.
I kind of let this play as I'm hitting the recite here, just to see as we were instructed to do, to not cut out the tough parts.
Like 3D.
I mean, I think it's great. You think it looks like you're doing a great job. It looks like you're kind of, for the most part, peeling towards the fovea, which I think is also a nice consideration in these cases where the retina is very thin, tractionally elevated here, and there's not a lot of structural support to the fovea. So sometimes peeling the ILM abruptly over the fovea can be problematic. So it looks like you're paying attention to that and kind of trying to peel towards the fovea here.
And this isn't coming off like one nice sheet, like on a standard macular hole. Like it's coming out in little bits and pieces, which I think can sometimes be frustrating. And, we tend to then grab extra fast or be extra quick. And I think you can get into trouble that way. So I think as these peels take longer and you're going like longer into it, like you have to, I don't know, take an extra breath and settle yourself a bit, because otherwise it's very easy to get yourself into trouble like at the very end, because you're becoming a little impatient. At least I am.
You saw we went back to the flex loop to try to segment that dangerous area because the peel was not going through there nicely. It was kind of just amputating there. So we just went back to the flex loop and massaged it a lot. And so here now we're just doing some peripheral cleanup, and we see a peripheral break.
So in this case, there wasn't very much subretinal fluid, right? There was a little bit. In these cases, when there's a lot of subretinal fluid or more, I don't want to spoil the next case, but would anyone consider peeling under PFO or using PFO to displace that fluid and maybe even making a retinotomy peripherally to drain it out? Or what about more advanced cases of this with more subretinal fluid?
I can speak, and I'll say that I think in general, I would try to, I guess, you could do that. I guess I would try to avoid making a retinotomy within that thin to macular area, right? Like I think if you were able to push it out farther nasally, maybe, but at least I didn't get the feeling that the fluid was the inherent part that made this more difficult. Am I correct?
Yeah, I guess I was just speaking to cases where there's a lot of more fluid in a case like this.
Yeah, fair enough. I mean, I think in those scenarios, I think it does make sense. And maybe you don't even have to drain. You can just flatten it out so you can actually peel and then, and then address the fluid afterwards, after you're done peeling. And we have something that we're going to show you, hopefully here in a second.
Question from the audience. I'm going to ask Natalia Callaway. So Tina asks, in terms of staining, tissue blue specific to ILM, whereas ICG could stain epiretinal membrane, and is asked as a question. So do you want to address, when you use tissue blue versus ICG and what you're getting with each of those stains, Natalia?
Yes, happy to. I think it's a great question that we're learning a lot about, particularly from the European literature. At least for me, I'm looking at that when I think about the tissue blue. But for me with epiretinal membranes, I actually typically stain that with steroids. I find that the ICG doesn't have much uptake there. And so I use kind of a dilute Canalog that I sprinkle over the macula to stain the epiretinal membrane. And then once I peel the membrane, then I go back and stain with either ICG or tissue blue for the ILM peel. But there is some wrinkling of the ILM, and sometimes you can use that to your benefit. If you find a wrinkle, then that might be a nice place to grab it.
Looks like a great outcome there, Eddie.
Initially, there was a nice
Beautiful.
outcome on post-op week 1, but and we can see some gas there still present, providing some form of tamponade. But on post-op month 1.
Oh, why'd you show that? You should have just kept the 1 week one.
Yeah, like 1 week, call it a day.
1 week,
Beautiful.
he's done.
Keep it awesome. No
Gas
one would have
there.
known better.
It was tempting. It was
So
tempting.
we don't co-manage our retina cases like you do in Cleveland, okay? Like actually see them at month 1.
Touche. Touche.
I think it's very
So the
interesting
COBRA
that this
strikes.
patient had like a reported history of a macular buckle. Was that, you saw no indentation of a macular buckle? Was that ever kind of considered in this? I mean, obviously as a first approach, probably not, but now are we thinking about it?
Considering
I actually don't use them. I haven't done them, but I know it's out there.
You can
Those
send them
actually-
abroad and they can get a macular buckle.
So, yeah, I mean, I think, go ahead, I'm sorry.
Question about macular hole. When you do this, obviously it's not. Some literature showed if you do a macular hole membrane peeling, if you reverse a flap to fill the hole, that membrane could promote the tissue regeneration, which was very nice. And not all the hole can be regenerated, but large holes, if you flip you don't peel off the LM completely, leave it and let them just flip over, cover it. And some, of course, they put the tissues and things and now have other cell transplant technology. But there was a very good publication by, I think was I forgot which, they flipped the membrane. They didn't peel off completely. That actually promotes the tissue regeneration through, they think the Mueller cell might be able to regenerate and fill the hole, and they would pull off. And you can see very nice in the limiting external limiting membrane, ELM, and the EZ zone, and all the others grow after the surgery. That I think something was very interesting. And that was sort of we always just peel off, the clean the better, but some they think you should leave it and let half of them reverse to cover the hole. So,
That's a great point, and it's a great segue to the next case. Why don't we jump to the next case?
Thank you.
Excellent. So great job, Eddie. Our next faculty mentor is Dr. Catherine Talcott from the Callaway Institute at Cleveland Clinic. She did her residency at Mass Eye and Ear and her fellowship at the illustrious Wills Eye Hospital. She's being joined by a superb second-year fellow at the Cleveland Clinic, Danny Mamo, who finished his residency at University of Minnesota and is somehow surviving working with Sunil for a little more than a year now.
It's Sumit's fault.
Surviving.
Good
He's only
luck,
here because of
Danny.
me.
That's all I can say. Good luck, Danny. Take it away, guys.
Thanks so much for organizing this. This is a great conference. I'm so excited to see all these videos. Thanks, Danny, for putting these cases together for us.
Yeah, for sure. I thank you guys for putting up with me. Can you see my slide here?
And
Yeah, it looks good.
So this first one is a 63-year-old guy who came to us at our county hospital with 2 months of vision loss in the right eye. He's count fingers. He's 20/25 in the left eye. The left eye, as you see below, actually had a buccal vit with SF6 years ago for retinal detachment, did well in that eye. And now he comes close to 2 months of a retinal detachment in the right eye. His nasal retina is attached. He's detached from 6 o'clock to about 2 o'clock. He has inferior lattice, as we'll see, and a hole within lattice, which we think is the causative break. And he also has a full thickness macular hole. He's emmetropic and no other issues. I'll share the video here.
So what were you thinking, Danny, in terms of surgical approach? Obviously, you're going to show us a video with a vit, but he had a buccal vit, did well in the other eye. What was your sort of thinking beforehand about whether or not to do just a straight vit versus a buccal vit here?
Yeah, so he had inferior pathology with lattice and a hole. He was pretty good exam, didn't see anything superiorly. There was some lattice, but I didn't see any breaks or holes. Because of the inferior pathology and the chronicity of it, not sure if there's any PBR developing, we decided to do a buccal in addition to a vit. He already had a PVD. He was phakic, but given the hole as well, and the success with the vit buccal in the other eye, we decided to do a vit in this eye as well, given that he had a PVD already.
Awesome.
So the retina was pretty mobile. We're using the Stellaris system here, and we're starting our core vit. And is my video a little jumpy?
I can't see the video running at all. I just see your title
Yeah.
slide, Danny. I don't know if I'm the only one.
No, I think
Yeah, I just see the title.
Yeah, try to play.
If that lens was 2 to 3 plus, would you do buccal vit phaco at the same sitting? Because you have to peel the macula at some point in this case.
Mm-hmm.
We have pretty easy access to phaco here. I guess we could have. That would have been a good thought. We do that pretty frequently here. I think if you're out in practice, it's a little more difficult, but given that it was only 1 plus NS, we decided to keep the lens for this primary surgery. We didn't know or think that he had a lot of anterior PBR at this case, but especially cases where we're suspicious of anterior PBR, we like to take the lens to make sure we get as much anterior retina as we can.
Mm-hmm.
Or anterior vitreous, sorry. Can you guys see my video now?
Can you press play? Let's see if it works. Yeah, it's working here in my.
Awesome, it's working. Okay. And just another question for the other faculty members, when I've had situations like this, I always, fix the MAC hole at the same time I'm doing the RD, but I've heard some people argue just fix the RD and then work on the MAC hole later. I was wondering if any of the other faculty members sort of do this in a staged approach, or if everyone's doing it all at once.
I think you should ask Danny, because he and I argued about this during the case.
Oh, okay. What do you think, Danny?
Well, I think I found out that it varies a lot by retina specialists. I mean, I think here the practice pattern is mostly actually to not take care of the whole of the primary surgery. And I looked into the literature, and actually there really isn't good literature to suggest. There is good literature to suggest that about the same percentage of holes close with a peel and without a peel after the primary surgery, just by taking out the hyaloid, putting gas in, relieving anterior traction with possibly a buccal. So usually I have not in fellowship. I think I've done 2 other cases prior to this one. This one, the hole was pretty large and it was chronic. We also were wondering if there was a MAC hole component to this RD. The original break was a small hole inferiorly. So we actually did in this case, but I've lost a lot of battles trying to convince my attendings to peel during these. So I am curious to see what other practice patterns are from other faculty on the panel here.
He beat me down, so I said yes.
So I have read that same literature, but ultimately the way I practice is the way that Catherine had mentioned. I try to fix both if I can in one surgery, and I just approach it as, if I have time, I will do this. But my primary goal here is to flatten the retina. I can go back and do it, but if I have a good view, I will try to peel.
I think especially in younger patients, if there's especially with like a traumatic detachment and a traumatic hole, try to fix those with a buccal, and in many of those cases, the holes can close on their own. And I think the main action point would be, like you were saying, Danny, is the detachment due to the hole, or is the detachment due to some other break that's not well treated or open? And if it's due to the hole, then I would address the hole. And if it's the hole's also there, then I think you're plus or minus depending on your practice patterns and how you're feeling about the case.
Show us what you got, Danny.
Yeah.
So here we're continuing with the peripheral shave. Had a buckle, so didn't require a lot of depression, although later we did do some when I make a little iatrogenic break, which you'll see later. But here, having pretty good control with the vacuum, the retina is very mobile, and going over the detached retina here temporally right now. He's phakic, so can't switch hands are the things that I'm thinking about at this time. We're approaching the inferior lattice here, where there is a small hole over there, as you can see, which we think is the culprit. And here, just shaving over the lattice here.
Looks like a good thing to put on a buckle in that case. It's kind of nasty looking lattice.
Yeah, the buckle was definitely helpful in this case. And here, we're really trying to get all the vitreous around this lattice. It was very sticky and very jumpy, enlarging the break a little bit there.
Oh, yes.
That one was on purpose. A little later is not on purpose. Here we're putting some triessence to make sure that the hyaloid is up, and it was.
Need to laser it, those letters.
Yeah, definitely going to laser those later very well. Here, switch hands. And I always don't feel incredibly comfortable because on the phakic on the opposite side where your light can't show you the vitreous well, but here the retina was attached, so it felt like I got a pretty good vitreous shave over there. And here, probably should have just put PFO down at this point, but there was still some superior vitreous that I was trying to get, and I make an iatrogenic break there superior, which luckily was at 12 o'clock on the buckle, and ended up using this later to drain actually during our fluid air exchange, which you'll see. Larger.
It was
break.
amazingly planned, well planned.
That's perfect.
Yes, it was perfect. Perfect. So one of the things I struggle about in these cases a little bit is, the schlaring can really come out of the MAC hole while you're doing this case and in the course of doing the bit. I was wondering if there's sort of any techniques that you sort of have learned, Danny, or other faculty members to sort of avoid schlaring coming out of the MAC hole and enlarging that to make it, making things harder for yourself.
Yeah, I think in this case, quite a bit. I don't know schlaring, but it definitely was draining from the hole at the beginning of the core bit. I don't know that I saw a lot of schlaring out of it. But I think obviously positioning where you have the mouth of the cutter and how much vacuum you have is important. I don't know if anyone else has any other tips.
In some of these cases, some of the you're fighting a little bit of your view in some cases, especially as patients phakic, maybe their epithelium is not so awesome. So, Kat, when you're working with your fellows, so you got to deal with the macular stuff. So you need as good a view for the peel at some point, and you figured out where your peripheral pathology is, but you still can go back and keep shaving and depressing. Do you ever say, okay, we're going to address the basics of the retinal detachment part of it, do the macular work, and then clean up the periphery? Or do you like to, deal with the detachment because that's what you came here to take care of primarily, and then hit the macular portion later? Like sometimes it's like a balance between what your view is going to give you versus, what you want to be perfect with.
Yeah, I totally agree. I think you need to be really cognizant of what's happening with your view as you go through these cases. And it depends a little bit, as you said, on what's the cornea status, what's the lens status, because you're going to need an excellent view to peel, especially if you're peeling under PFO, or if you would like to peel on detached retina, peeling there. I usually try and get most of the peripheral stuff done if I can, and I usually jump to sort of depressing for the fellow as we're shaving, but I definitely check back on the view and make sure that's okay, because that's, they're going to be the hardest part about this case. These are cases I definitely use Visco for to sort of maintain, it's definitely fine to go and peel and then go back and shave some more. Your view doesn't need to be as good for that, but I think it depends on case by case.
So we decided to peel here, and what are your thoughts on, so at the county, we do have blue as Dr. Sharma mentioned, but at the county hospital, we just have ICG. So we use ICG. What are your thoughts on, we used a very small amount, as small as we thought we could, and the lower concentration, but what are you guys' thoughts on putting ICG in now versus putting some PFO in first.
Did you use that low concentration and ask really nicely for it not to go into the hole? Like, did you say pretty please when you squirted it in?
Basically.
I mean, some's going to get subretinal no matter what you do. You just have to be careful. I definitely let things sit less than I do for normal cases. I don't know if other people do differently.
I mean, you can put a PFO down first, drain out of your now peripheral drainage retinotomy that you made, and then take the PFO back out, and leave a small marble over just the hole, and then put your ICG in, and that avoids or reduces the amount that'll go subretinal. But it's still tough. I mean, you can still get, even with that, you can still get some that go subretinal. You can use blue, or you can do just what you did here and just be very careful and pray.
Mm-hmm.
And one of the things we talked about, because we did talk about this, was that one of the concerns, you look how large that hole is, there's still a fair amount of traction. Putting perfluorine down like a pearl of it, you also risk that perfluorine could go subretinal through the hole. So if I had to pick, I'd probably pick a little ICG over a little PFO. And so that's how I think we came at it. And also with D5W, that's how we dilute it. We end up using such a small amount on the big scale things of where we used to use it when I first started operating, that I think, again, you hold the light at a certain distance. I think your risk of toxicity is much, much lower now. So that's how we came up with our plan.
And I think that's all perfect. The other thing to remember is you don't need the entire macula perfectly stained, right? And we're used to that now. We like it when we do typical holes, but even if you get a little bit of space where you can get your opening, we can still visualize what we need to see. So as little as you can is probably the right answer.
Yeah, and to Ed's point about the brilliant blue, yeah, I mean, we just don't have it at our county. That's all. We have ICG.
So I had never peeled under PFO before, and
You didn't tell me that.
Given the size of this hole, we thought about maybe doing a flap. So we put PFO down after we put ICG in, and then we actually just stayed under the biome, which was kind of nice, and didn't use any other lens because I felt with the flex loop we had a pretty good control and pretty good view. So I'm here just shaving some more vit around that break. So here
I'm curious if everyone here peels under PFO, or do people like to peel on detached retina? I personally peel on detached retina. I kind of prefer that. I'm more used to that, but I think I'm in the minority at Cole. And if anyone else does differently.
I peel under PFO. I think both situations are challenging in their own ways, but this is just the way that I've done a few cases and move forward with it.
Mm-hmm.
So it took a few strokes for me to get the feel of starting the flap, but then once I started it, it came pretty nicely. And then once we thought that it was kind of coming in a nice sheet, we thought about doing a flap. It was gently going all the way around. The contrast was not as good temporally, given the folds from the regentosmous detachment, but we got enough of it temporally and superiorly here.
Did you feel like, maybe you could talk us through how it felt differently to you? Was it more the proprioception of where you were onto the surface, or was it not coming off as easily? Could you talk us through that?
At first, it didn't come off as easily as I'm used to. I think I had to do put a little bit more force down on the retina, and the retina just felt, I don't know what the right word for it, maybe a little bit more gummy. But I felt like when I saw the retina being pulled too much, I just stopped, and I felt that with the PFO, it just allowed the retina to settle back to its normal place pretty quickly. Once after the first few strokes, once I got the hang of it, I didn't think it was dramatically different. The retina just felt a little bit more gummy, like maybe pushing down on a trampoline or something.
I think that's well said. I think you were really well controlled, and I think using a diamond dusted or a flexible loop is the key on this, as opposed to using a forceps. I think once you get an edge, it's really nice to keep working with that. and just keep working on the edge.
Quick question: when you're doing a peel and like propagating it with like a flex loop or a Tana or something, where you're actually like pushing against the retina versus like an ILM forceps to propagate it, do you guys consider like the nerve fiber layer or like avoiding the papillomacular bundle, or just going horizontally and not going like vertically to not like cut through, or not cut, but like not disturb the more fibers in the nerve fiber layer? Or is it atraumatic enough that you can just peel entirely with a flex loop?
So we had a paper a couple of years ago where we looked at this with intraop OCT and postoperative OCTs of various techniques with our ILM peel. We essentially found that all of them had the exact same amount of like dissociation. So I'm not sure it's necessarily, I think it's the process of ILM peel more than anything else that I think you'll see it. So for me, in this scenario, I think of safety, right? As far as like what's gonna give me the better, what was gonna give us a better peel at this point, or to get the edge. It just felt like the flexible loop was. But your points are well taken. The papillomacular bundle isn't the most ideal place to be with this. We try to avoid it in this scenario with this kind of pathology. The way I thought about it at least was try to get this whole flap. And you'll see when we started it more superiorly, we were pretty far out, but it's still the same concern in a case like this.
Did you consider doing microperimetry in that paper, or was it all structural? Or?
Oh, it was. These were all, and so that's a fair point in the paper. So it's Runkle is the first author. We did not have microperimetry on that one because our microperimeter is currently holding up our laser interferometer downstairs. So we just don't use it as much.
Thanks.
I think
I
it's
didn't know
great
that. That's awesome.
I think it's great you're using a flap here, because that's one of the great things about peeling under PFO. That's actually one of the things I love about it, because you can get these huge sheets of ILM, and so you're kind of using that to your advantage. So I think that's really cool.
One of the things that Edward Wood's been teaching us is using PFO not just in peeling, but also to help induce PVDs. I think he uses that in some of your PEDS patients sometimes. I think that mechanical force really can't be understated. It can help in different ways.
Yeah.
Can you expand? What do you do there, Dr. Wood?
Oh, so in some cases where the hyaloid is really very taut, I will make like a rent in the posterior hyaloid, as we were talking about, maybe in the nasal macula or wherever I can get an opening, and elevate that slightly. But instead of pulling, exerting a lot of AP traction with whatever instrument I'm using, whether it be forceps or the cutter, I might at that stage decide to try to PFO dissect the hyaloid up further. If I'm going to be already using PFO, I'll use it sooner than I would later. And instead of just putting it over the nerve, I'll put it through that little hole in the hyaloid, so it gets under that plane. And now I've established the surgical plane that I'm going to be working on, and then using that to walk out the hyaloid. Just an efficient use of tools if I'm already using PFO. I wouldn't probably do that to induce a PVD if I wasn't already putting in PFO in the eye, but just, yeah.
But I do something similar. I'll use the Hubbard viscodissector, and I'll put like a viscoelastic through it. So I'll create that little hole with it and actually use the viscoelastic to dissect. And the Hubbard viscodissector is nice because it has a little curve on it. It's 27 gauge, and you can really kind of adjust the curve to follow it out. And I'll put it on the viscous fluid cannula, but you can also do it directly, just inject slowly with PFO as well. I think your technique is awesome. Just using that to like essentially viscodissect.
Yeah.
Cool. Thank you for sharing that tip.
This is looking really good, Denny. Did you just kind of keep this, flapping to temporal, or did you try to go all the way around? I can't tell if you're.
We left the supratemporal edge, and we'll see that here at the end during the fluid air exchange. So the end of this becomes a routine detachment. So we laser the superior now retinotomy, and then we also laser the inferior lattice, like someone mentioned earlier. And here, depressing for myself and lasering, which I found is a nice technique. and then going to fluid air exchange here, drain through the larger break superiorly. And then we wanted to hopefully make the flap fall over by draining nasally here and just allow the forces of the fluid air exchange to bring the flap over. But it didn't quite work as well as we wanted. So we actually nudge it over here. I'm nudging it over with the soft tip. Or here we're trying to drain nasal sweat. I think we squirted some BSS down nasal and then tried the fluid air exchange, but then it didn't work. So here I'm nudging it over with the soft tip, and then it goes over the hole there nicely. And then we finished the fluid air exchange, and it didn't move, so that was nice. And then
Wait, what did you do with the BSS? Can you explain that again to everybody?
well, we kind of, so it didn't flop over during the initial fluid air exchange. So then basically added more fluid, like BSS drops that we were going to do anyway to get rid of the PFO. We added that around the disc and the nasal macula, and basically just tried to do a fluid air exchange again, just to try to not need to manipulate around the fovea with my soft tip under air, but it didn't work. So ended up nudging it over with the soft tip in the end. And then we closed the case. We had put a 40-50 on the side at the beginning of the case. I don't think I mentioned that. And yeah, the patient has C3F8. He's attached under gas right now. We haven't gotten OCT though, and I've not seen him actually to see if the hole is closed enough.
And unlike Eddie, I will not show you the 1 month follow-up of OCT. So, we should move on to the next
Discharge him
case.
before month 1, it'll be fine.
He looks perfect. End of the beautiful case. That was a really nice case, Danny.
That was a really
Good job,
nice
guys.
job.
Yeah, well done. Before we go on to our next case, I want to introduce 2 of our other faculty members who are here today. From Cleveland Clinic, Dr. Sumit Sharma. Say hi, Sumit. We can see your face then.
Hey, how are you?
So Sumit did his residency at the Byers Eye Institute and fellowship at Duke prior to spending some time in London as well at Moorfields. So thanks for joining us, Sumit. And Natalia Callaway. Natalia, where are you? Say hi. Natalia Callaway is a member of our faculty here at Stanford. She was a Bascom Palmer resident and did her fellowship with us. And is now doing some exciting work in her spare time at Genentech. Well, actually, most of her time there, but it's great that she's able to join us. So we'll go on to our third case. So kind of going to some old school principles of scleral buckling. So our presenter is one of our Stanford second-year fellows, Kapil Mishra. Kapil did his residency at the Wilmer Institute, where he'll be heading back next year. Edward Wood will moderate.
Okay, great. Thank you. Couple, you can go ahead and present whenever you're ready.
Great, thanks. Sorry. Okay, great. Thanks, everyone. Thanks, Prithvi, for the introduction. I have no disclosures. So my case is pertaining to a 26-year-old male who presented as his first visit to the Byers Eye Institute with decreased vision in the right eye for about a week. He has a history of retinitis pigmentosa complicated by CME in both eyes. He was treated or at least followed elsewhere, but not really treated for the CME. He has a history of moderate myopia as well, about a -5 spherical equivalent. So on exam in the right eye, his visual acuity is decreased to 2250. His left eye is kind of at the baseline, at least per records of what his right eye was around at 2060. Pressures were fine. And on an ultra wide field fundus photo of the right eye, he didn't have a PVD, but he did have significant vitreous syneresis. And you can see temporally he's detached with several atrophic retinal holes. There's subretinal PVR. There's some atrophic appearing retina inferiorly as well. And this is his OCT of a raster serous in the macula, which shows extensive schitic changes due to the CME, and obviously detached. I just wanted to quickly show you the left eye. The left eye, he's attached, but he has a very atrophic appearing retina. This is the fundus autofluorescence through the optos, and then you can see the significant CME through the macula. So before going into the surgical video, and Prithvi kind of hinted at what we decided, just to summarize, it's a young phakic, no PVD, has subretinal PVR, Clearly, the peripheral retina is thin and atrophic. What would the faculty do in this situation? He's MAC off. Would you just do a buckle? Would you do a vitrectomy combined? And then considering his underlying diagnosis of RP, does that play into your decision making at all? With perhaps less phototoxicity with the buckle versus a long fit.
I love it. Capilla's auto moderating, which is very Cobra-esque. So thank you.
I think in a young patient who, sorry, sis,
No, go
Sunil. I think in a young patient whose phakic doesn't have a PV and like a PVD, I mean, trying to stay out of that eye, I think is a great idea. So I usually try and go for buckles here. I think I find that when you look at these pictures and you see the PVR, often people, especially in training, want to go in and sort of remove those membranes, but actually, if you often just do a buckle and you drain, the retina will settle out and those bands won't cause any problem at all. So my first approach would definitely be to just do a straight buckle. I don't know if anyone else feels differently.
Buckle drain, go for it.
I agree.
These
Buckle drain, young patient, no PVD.
This is your made for. How old's the patient? I'm sorry, remind me, please.
26.
Yeah, I mean, in this scenario, it makes a lot of sense staying out of the eyes, trying to avoid lifting the hyaloid in this, because I think it'll be a challenge. It's a much better option for this patient, I think, to do a buckle drain in this case. So that's what I would do. And
when would you consider to drain? If, let's say, you put on the buckle and it's lying nicely on the buckle, but perhaps there's still a little bit of fluid, but the retina follows the contour of the buckle, would you still drain or kind of watch?
So I'm going to reverse and ask you when you drain in a second, but I would only drain when the fellow tells me he's drained once previously, like Danny did before. So when would you drain? What's your decision-making process, young man? When you put the buckle on, when do you decide that it's time to drain?
Well, I don't think the brakes have to lie flat, like pushed up against the buckle, but Edward and I talked about this a little bit, but if the retina,
so you're blaming Ed now. You're blaming
Ed.
Ed.
It's okay. If his answer is wrong, it's me. If it's right, it's him.
But if the retina seems to already kind of lay in place and follow the contour of the buckle, like if you can see the buckle effect underneath detached retina, then I don't think it would be unreasonable not to drain. I think it's particularly interesting in this patient because I'll get to it in a little bit, but with RP, they have an RPE pump dysfunction. So there's more of an argument to drain to kind of help him out because he may not actually drain. The other thought is if it's been chronic as evidenced by the subretinal PVR, then it's perhaps pretty thick subretinal fluid and you may want to help that along too by draining.
I agree with everything you said there. I mean, I think it's motor oil. That's the thickness. That's the viscosity of something like this fluid. So it takes a long time for it to go away. We know that the vitreous is the tamponade, right? In a case like this, because the hyaloid faces down. But I would say that unless I'd like to see the break relatively flat, doesn't have to be complete, but I like to see the break at least lying and there's a release of some traction there. I personally like when it's flat. Then I know I have a chance that it's going to work really well. So that's my decision-making process. So I would agree with Ed on what he told you. I think it's correct.
That's what the fellows always say.
Sunil's getting old because he's agreeing with everybody today. I don't know what's wrong.
It's just, I have my kids, they disagree with me constantly. So I got to agree with everybody else.
Somebody does. Okay, good.
Yes, exactly.
All right, awesome. Thank you all for your comments. So for the sake of time, because I know we have another case, we decided to go with the primary buckle. We did a chandelier as well, just because I was staffed by Natalia, and it's just a great teaching tool, gives great visualization as well. And so we'll show you, we did this under the scope.
I really like chandelier buckles. I think they're great teaching techniques. I mean, I think one of the hardest thing about doing straight buckles is the view is so much harder than you think it should be. You see these people in clinic, you can see the break, and then you get to the OR and you're trying to find the breaks and it's hard. And I think really it's a really nice technique so that you have the shared view, and you can really feel confident with what you're treating.
Yeah, absolutely.
That was exactly my reasoning for the chandelier. I also really like seeing the cryotherapy. Just make sure it's exactly where I want it to be.
That is the best reason to do it, because there's not, I think, unfortunately, we don't cryo as much as we, not unfortunately, it's just the way it is. So I think it's a learned technique, and having seen over cryo, it's nice to be able to regulate it. And I also think the finding all the breaks is easier with under a chandelier and a biome. I will ask, and maybe people can answer, what's the downside of doing the chandelier? Is there a downside when you were doing this? Or you can play the video.
Yeah, actually,
Yeah,
you can see it in the video.
Yeah, let's watch the video a bit and see.
Fine, I'll shut up. Thank you.
So we started with, I mean, I'll just briefly say the steps of buckle. We started with the 360 peritomy. I was accommodating pretty early on in the case. So we're just kind of dissecting through, and then, you know, dissecting the 4 quadrants with the Stevens. Hooking the muscles.
Nice.
I'm constantly
this is us
doubting
putting
the
the
cornea. and all this.
And this is what I wanted to show it to the point of when is it, you know, when do you consider not doing a chandelier, is when we went in with the chandelier here, you can see a lot of syneuritic vitreous coming out. So there's a possibility of causing, you know, tear, kind of like a trocar tear, essentially where the chandelier is. The other thing is he's phakic. I did read somewhere, I don't know what the faculty thinks about the position of the chandelier in relation to the detachment, whether they're phakic or pseudophakic. Because someone had mentioned about doing it 90 degrees away if they're phakic, and 180 if they're pseudophakic. Does that play into people's decision making for the faculty?
I think that's a good question. I've always put mine about 90 degrees away to sort of optimize visualization, but you definitely want to be cognizant of where you're putting it and think about where your breaks are and try and sort of get it there. But I don't do a different like clock hour away if they're phakic or not.
I'll also bring up, you know, I really enjoyed the chandelier buckles, and we actually wrote one of the early papers of the US experience for it. And I think that there's good experience and bad experience with chandelier buckles. I think one of the things to keep in mind is what you talked about here with the fluid coming out of the port. And if you're moving the eye around, even when the light is in and the light falls out, then the eye can soften without you knowing about it. We don't often have plugs, and I wish they would include a scleral plug in the chandelier case, but I have now opened a valved cannula that I put the chandelier through. So even if the chandelier pops out, I have some protection there. So it's a waste of money because I have to open like a pack of trocar cannulas, but you know, I'll stick that in there. The other question for you all is, how do you actually position your chandelier? Do you just, you know, do you bevel this trocar going in? Do you just go straight in? And how do you actually place the chandelier light itself? Do you put a loop? Do you not put a loop? Because it's kind of stiff and it can easily fall out. So I'm going to shut up.
I'll speak. I'll be here. I'll say, you know, Prithvi, I've had the similar experience. I think there's a lot of bad things that can happen while popping this off. So I put a loop on mine. I tape it down. I will, if it's not stable, I will take it out, suture it closed, and just throw on my headlight, because I'd rather have this thing stable. I have put in this scenario also if you already are opening a pack of 3 trocars, you can put a couple in and you can move the chandelier around. The thing to remember is when you take the light out, to make sure you're not dragging vitreous through. So to make up for, I think what Ed brought up on the chat, I think it's hard to see underneath the chandelier in that area. So I like having the ability to look across the eye. That to me makes at least how it works well for me. But you're manipulating it constantly. Every chandelier buckle video looks great. It has not been my experience that every chandelier buckle is a great experience. So, you know, just understand that you can make things worse here by having that in there.
I'll kind of be the contrarian, I guess. I don't really do chandelier buckles, not because I don't think they're great. We didn't do a lot of them in training. We did more sort of, I guess, old school traditional buckles, I guess.
You sound like the old man now. I'm
And
just saying, passing it on.
yeah.
Back in the day,
So I'm
we
kind of
never
like,
considered
yeah,
it
not
about-
entering the eye, but one thing that I do, and I don't know if anybody else does this, but if I'm not doing a ton of cryo, I will do the cryo first before scrubbing and everything like that. So I find it a little bit easier than doing it all with the gloves and the plastic bits and getting the indirect and someone putting that on my head and everything. And so doing that first and then putting on the buckle. I don't know if
But
anybody
you don't
does
open
that.
conj, you just go and cryo directly.
Transconj cryo, yeah, if I'm not doing a lot of cryo. And then I can sit down and just focus on the buckle part.
I don't, but I'm going to consider that. That's
Yeah.
Not a bad
that's nice.
idea.
You know,
Yeah.
the only reason I don't do that is more because I think with manipulating the muscles, I probably get a, more complete view. But I think your point is well taken. Do it comfortably so you can get it done. I guess you can always relook and see if you've missed something, and so you're doing, maybe less with all baggies. I think that's a great idea.
What about for
In terms of Prithvi, your prior question, though, I go straight in with the chandelier. I try not to bevel because I'm going to be sewing it anyways, and I'd rather have the angle of the light be the way I'd like it to be rather than have to deal with the bevel. And I go 90 degrees away if possible, but I don't want it in my way either.
Danny, you had a question?
I don't cryo a bunch of tears. What do you do for, I just had primary buckle last week where this, the break was right underneath the muscle. So it was nice to get underneath the muscle and cryo. So Dr. Wood, for breaks, does it matter crying over the muscle a lot or not really? If you're doing it transconj?
I think it's not ideal, I would say. And I think if there is a large break under a muscle, I probably would take down the conj. It's just, I wouldn't say it's a rule that I hold myself to, but I would just say that it's something to possibly, buckles are always, there's this sort of like awkwardness to different parts of buckles sometimes. And it's always just helpful to find your own ways of making yourself more comfortable with it, because then you want to do it more. And I just love doing buckles, and it's so great when buckles work, and you just feel like such a cool doctor when you do a good buckle and it works. And also it's great for the patient. So if you can do whatever you can to make yourself feel comfortable and still be efficient with the buckle, I think that's great. But we cryoed tears in fellowship. Actually, that was the primary way we treated retinal tears, small tears. So we did a ton of transconj cryo in the clinic. I'm not saying that that's the best thing to do. I'm just saying that we had experience with it. And so that's what I feel comfortable doing.
Phil, show us what's going on.
Great. Thanks, everyone. So now we're in under the reside, and I just love the views of this. This is gives us a nice wide field view, and we're kind of looking around. I don't put too much of it into the video of us kind of identifying each break, but I just show us doing a sclerodepression 360, and there are no breaks nasally. It's all kind of temporally where we had seen preoperatively. So we're marking the posterior break. We check like several times just to be totally thorough what the most posterior break is. And I believe it was 6 millimeters behind the muscle insertion. So we mark it there. And then in terms of the band, we decided to go with a 42 band with the anterior mark being 4 millimeters posterior to the insertion, and we suture it in, of course.
Sunil, I think I hear your pain when you're coming in and out with the biome or the recite, marking, going on the inside, outside, back and forth. Sometimes that can get clunky. You end up knocking the chandelier out sometimes, working inside out. I don't know if.
Yeah, no, I mean, I think you see it here. You guys took out the chandelier. I mean, that's what I would do. In this scenario is get the chandelier out of the way when you don't need it. How far did you make your? I know it's 4 millimeters from the insertion. How far were your bites from each other?
They were just a little bit over 4 millimeters. So with the 42 band being about 4 millimeters, just to be able to accommodate that, we didn't do too much more after that.
Yeah, I'm an imbricator. I tend to add, essentially one on each side. So I tend to add 2 to mine. So in a case like this, I'd probably put a 40-50, and I'd probably make them 7 apart. or if I used a 41. Those I only use a 41 and 40/50. That's it. That's all I use, and I tend to imbricate because I get the buckle height I like each time.
And then to your point, we ended up switching the chandelier
Right.
to a valved one just because the eye was losing pressure at a certain point. I do wonder though if you feel like it. I don't know if the chandelier fits as well in the valve.
It doesn't.
Or yeah,
Does not.
It doesn't. It doesn't hold as well. That's.
But it's good enough, right? Like when you need it for what you need it for, as long as your assistant is maybe watching that area, so it doesn't fly off of you. But yeah, it's not perfect, but it's probably good enough. Better than
And somebody in the chat showed actually using a light pipe.
Yeah, that's
and using a lure lock on it and putting it in the eye using the lure lock so that it on it so that it stays in and doesn't go in too far. But it's a great.
Yeah, it's a nice technique Ephraim described, and it's on that AAO site, and Arjun wrote in there he used it as well. So I might try this. It looks pretty cool. Go ahead, man.
So I'm not going to show the entire part of us looping the buck band around, don't worry. But just, we put the sleeve supranasally.
The chandelier is out completely at that point, it looks like.
Yeah, exactly. So then this is just the cryo part, is just really nice to be able to visualize all the atrophic holes.
Your attending is feeling great. This is like this make sure your blood pressure doesn't go up when we can watch you cryo, especially the temporal stuff.
Exactly. I think this may be the last one. All right, and then to the point of the drainage, so we did decide to drain. I think this would be a good opportunity to kind of see what the faculty do, but we took a 64 blade and we cut down to try and expose the choroid, and then diathermize the scleral lips. And then we used a 25 gauge needle with part of the Watsky sleeve just to do it as kind of a backstop to enter in.
Part of the reason for the chandelier was to get a cool video of the drainage, but the drainage came so quickly that we don't have that image.
So your band wasn't tight at this point, it was loose.
Correct.
Yes.
Because there's a risk of retinal incarceration if you tighten the band too much prior to the drainage, right? Or what are your thoughts?
There's also a risk of the eye getting very soft and potentially getting choroidals as well. So I think it's a balance between the two. I tend to place my band, tighten it, and then use a needle like you did, not guarded, but not without a cut down, but in the bed of the buccal within the area of highest detachment. So I crank it pretty tight, and when the fluid comes out and everything equilibrates, usually the pressure is miraculously like normal, and the buccal height is just fine. I think I always think about it as having high pressure to ensure that something is coming out where the needle track is, but not keep it so soft that then you potentially get into the risk of bleeding or something like that. So
yes, this is you and I were talking about the same person. It's the Glenn Jaffe technique, and I learned it from Glenn as well, and I teach it to our fellows. I love that technique of pulling up the buccal, and you can actually, with the chandelier especially, you can watch the retina drain. Now you have to, the nice thing about it is you can see the needle in the subretinal space, and the bad thing is you can see the needle in the subretinal space. So it's, but you can see it fluttering down. And remember how we talked about the end point is to try to get the break to flatten or to be at least on the buccal. You can see when that point is, and you can pull the needle out at that point. So it's a really nice way to modulate it.
Yeah, so Danny and I just did this on Friday. Danny, how did you feel when you were doing the needle drainage? What did you say to me afterwards?
I was scared, blankless.
So I'll say
I would agree with that. It's frightening.
As cool as the chandelier buccal is to see the cryo, to me, the greatest benefit is to be able to demonstrate subretinal fluid drainage with a needle. Because otherwise someone has the hat on, the assistant is like in this funny position trying to position the eye so that the person doing the drainage can get the instruments in place. That's the best part about doing a chandelier buckle. Now, back to Sunil's point, and I hate to agree with him all the time, but the hardest part is also trying to manipulate this with the chandelier, right? Because you're trying to slide your needle in through, depending where the detachment is, you've got the reside or the biome there. So things can get clunky, and often it could happen like you found, Natalia, you're trying to get everything into place and you've entered and it's done. And like you missed the whole thing under the microscope. And suddenly you feel like ooh, I'm a little uncontrolled at that point. But when you can do it, it's a great way for fellows to be able to actually see that process. Otherwise, it's kind of like mystical. Like you just, someone's putting
that's when
on.
I would move the chandelier in that point. Like, so I would take the light out.
Yeah.
I'd go 180 degrees from where I'm about to drain, so you can illuminate exactly where it is. So now you have your hands kind of positioned apart, and it becomes a lot easier. So when I do this, I move if I don't have extra torque and candles in, I move it. And I agree with you. It's easier to teach it under a chandelier than it is with an indirect. But when I think Arjun's on, I taught Arjun how to do this, and he did it with an indirect, and my heart was fluttering as it was happening. But it works really, really well, and it's a technique I would encourage all of you to kind of see, because it's one more tool in your toolkit.
Yeah. So I've learned a couple really important new things on this case. One is, don't worry about making additional sclerotomy holes. I think I've kind of, felt like I put the chandelier in one spot and that's where it's going to stay. But, adding other parts, other sclerotomies, maybe it's not the worst thing in the world. And then Edward told us that you can cryo before you scrub, which I always thought was like not allowed, but now I'm empowered. This is great.
Maybe we can teach Prithvi something else in this last few minutes.
Arjun makes your heart flutter. That's all I know.
Yeah, that's true.
So this is a post drainage. I'm not showing it very well in this video, but the fluid has definitely come down, and we're just kind of looking around.
Sumit, do you ever go back in after like one drain and it's just not enough? Do you, what's your threshold to drain it completely dry with a second puncture?
Well, if it's like motor oil type fluid that comes out, then I think you need to try to get more of it out. But if it's the, thin fluid and your brake is flat, then I'm okay with leaving posterior fluid as long as the brake is flat or nearly flat. I'm okay with the posterior fluid, and it'll flatten out, and it doesn't be there initially.
Let's see what it looks like, man.
All right, so then we get a nice buckle effect here, and then now we're just tightening the buckle.
There's a nice needle that Will Park has put together, which is actually it's like a small little hook. It's 90-degree bend that allows you to slide in under the buckle and then just kind of turn, and then you're in. So you don't have to deal with like this long shaft that you have to manipulate yourself to get into position. You can use that as another way to access that space under your buckle. It's I don't know who makes it. I'll find out for next time.
Yeah, I'm blanking on the name of it, but we use that to drain under chandelier buckles in fellowship, and it's really nice. You can kind of manipulate it and then slightly turn when you can see the indentation. And it usually comes on, I think, a sleeve as well, which is kind of nice.
Vortex, yes. Thanks,
Yeah,
Danny.
it's Vortex.
Yeah.
So we talked a little bit about this just for the sake of time. So I just want to show
the Vortex one. Sorry, just to go back for a second. The Vortex one I think is a little different. So the Vortex one is the one that comes with a bulb, and then it actually has a needle that extends out. So you can actually push it out and extend it out, and it actually connects to the extrusion line. So you can actively extrude with it. There's a different one that's angled. I'm not sure who makes the angled one, but that's a different needle.
We will find out for next time and report back. COBRA 2.
Great. So this is a post-op month 1 photo. There's just a tad bit of fluid along the slope here, but it's been progressively getting better. And you can see the cryo scars. It's a good buckle height, so he's pretty happy. Just for the sake of time, I just wanted to briefly mention the study from Moorfields where they looked at all their eyes with retinal detachments and RP. And there's a percentage that were exudative and tractional, but the majority of them were rhegmatogenous. Then 56 underwent repair. It's a young age. Their mean age was 33. But there have been other series where the mean age was even younger at age 12, like in the 20s. But they had all sorts of combinations performed to repair it. They noted that no cases had a complete PVD, that most of the time the hyaloid is down. And they actually had a pretty good primary attachment success rate of 76.2%, and then a final attachment rate of 85.7%. And some of the things that they mentioned is that the natural history of RP is pigment migration from the RPE to the inner retina. So they've noted that the retinal detachments tend to happen more in younger folks than in older folks, because the older folks already have these broad adhesions. So they're kind of tacking down their retina due to the disease process. And then some notes that they mentioned for surgeons is consider turning down the light pipe if you're doing vitrectomy, just to minimize phototoxicity. And then they also advise doing an external drainage because the RPE pump is dysfunctional. So great, thank you, everyone.
Great job. Great cases and such. We're going to stay on time. We had one more case prepared, but Prithvi talked too much, so we're going to have to do that next time, I guess. I'm going to leave a final comments for faculty. Any last words of wisdom before we say goodbye? I'm going to remind everyone we have another one of these October 25th. We're going to change up the categories. We encourage you to reach out to us, and if there's something you really want to see, we're starting this. This is kind of new for all of us. This is not going to, we may change the format. We may allow other people to present as well. So we want to try to make this really fun. So if you have suggestions, we're certainly open to hearing from you to make this fun. I hope everyone did have a good time. Prithvi, any final words, sir?
No, thanks to Sunil for masterminding this COBRA Part 1. It was, I think I learned a lot.
Great.
And to our faculty as well, and our fellows who really get the real praise here for putting their work out there for everyone to look at, learn from, and for us to attack at every step. So that takes a lot.
And thank you to the audience for being great participators and blowing up the chat. It's a lot of fun for us, and I hope everyone gets something out of it. I learned that Danny never tells me the truth in the operating room, which is nice to know. This is a good thing for all of us to hear. Good night, everybody. Please stay safe and healthy, and we will see you hopefully all October 25th. Good night.